It's a pleasure to have you here. Today we're going to introduce the Blue Circle Voices. This is about a year-old group of people living with diabetes and their loved ones and caregivers that the IDF established to be a bridge between those of us who have diabetes and creating advocacy efforts for us and with us. So there are actually 130 current active members in the Blue Circle Voices from 58 countries. And even though it's somewhat dark, I think we have a few people in the audience who are Blue Circle Voice members. So I would just like you to stand up so that we recognize you. Thank you all. And there may also be some people, some young leaders here with the IDF group. Do we have any young leaders? If you would also stand up, let us appreciate you for all your hard advocacy work in your country. Thank you. So the Blue Circle Voice group members are, as I mentioned, kind of a bridge for IDF to really understand the real picture of what it's like to live with diabetes, what it's like for us to live with diabetes in our countries, and we are advocates on the ground. In some way, I say we are foot soldiers because we are living with our condition and we are aware of what's going on in our country and we are advocates. And one thing that we know is when there are actually advocates in a country, everyone does better. And it's interesting that the goals that we're all working on, the Blue Circle Voice members and the IDF, are pretty much the same. The three top major goals are increased access to care and affordability of medicine, better education, and ending discrimination, and diabetes prevention. And actually, one way we know that our goals are shared is part of what the Blue Circle Voice members do is participate in surveys and questionnaires with the IDF to report back on what things are like in their country. And so we discovered in the first survey that the Blue Circle Voice members took that we actually had 83 participants from 43 countries, which is 66% of our membership, that stood up and reported. And the biggest issue was, as we agreed, access to care. And 39% reported difficulty affording medicine in their country as a current situation. So again, as you see, the goals are united: access to care, affordability of medicine. The second thing that we learned from the survey is people are very concerned about getting more education to people living with diabetes. The prevention of complications was definitely a concern for those of us who live with diabetes, and ending discrimination. So I think one thing that's important to realize is these three goals are essential for people living with diabetes. And I want to say that there's something else that we have a right to, which is not just to survive with diabetes, but to thrive with diabetes. To be living with a sense of well-being and that we can be productive citizens for our families, in our lives, in our countries. So I think we want to say that people with diabetes can, in my language, flourish, not just survive, and that we, living with diabetes, are all entitled to this. So what we want to do for you today is I'm going to be introducing our three panelists. They are all Blue Circle Voice members. They come from 3 different countries, and they're each going to speak for about 15 minutes and give their perspective on their advocacy efforts, on what they're doing in their country and the state of their country, what we're learning from them, which is all vital, share some of their stories. So I think it will be a very interesting talk. And then afterward, I'm going to come back up and speak a little bit about discrimination. Then we're going to have our panel answer a few questions, and we're going to invite you to ask questions as well. So the first speaker I want to introduce is Rakiya Kilgori. And Rakiya is from Nigeria. And I have to tell you that she just arrived today, and she's not feeling 100%, but she said, I am coming. I need to come. I need to be there. I need to speak about diabetes in my country. I need to learn and bring back that learning. So when I first met her just a short while ago, her commitment really amazed me. So Rakiya, in her country of Nigeria, herself has type 2 diabetes. And she will share her experiences about access to care. And she has participated in food and medicine drives and donations, and she has worked very much with the local people in their local villages. And she will also share a little bit about what it was like for her to be diagnosed. So please extend a warm welcome to Rakiya Kilgori.
Thank you very much for giving me the opportunity to come and share my experience with diabetes. And this is to motivate others who are in the same line with me. As she said, my name is Rakiya Kilgori from Nigeria. I have type 2 diabetes. It has left me with eye problem. So I have eye problem. I married at the age of 16 years through an arranged marriage. As in my society, girls married at the age of 12. Girls are to be in powder. They are not allowed education, but access to education. But things are changing now for the better. I tried to break the genes. I went to College of Education to obtain NCE, National Certificate in Education, a letter, BA Ed, Bachelor's Degree in Education. After my NYSC, National Youth Service Corps, I found myself back to powder again. I was at home doing nothing. I was so depressed. I started eating anyhow. So I became obese. I was very fat. I came up with complications of arthritis, weakness, frequent urination, and thirst. I traveled to Cairo to seek for medical help. The doctor looked at me. After investigations, he said, you had diabetes. I denied. I told him, I have never inherited diabetes. How can you say I'm diabetic? Look at your women, they are very fat. I'm not diabetic. So I came back home and continued with my lifestyle because I don't know, I was not aware of diabetes. Nobody told me, there was no awareness that time. After some times, with my wrong lifestyle, I came up with complications again. I was admitted at the hospital, whereby I saw so many people with complications, amputated legs, blindness, and so many things. That was the turning point in my life. There and then, I resolved to dedicate and I decided to love, dedicate, and sacrifice my life for the cause of diabetes. Immediately I was discharged from the hospital, I joined Diabetic Association of Nigeria for me to have more insight about the disease and also help others on how to prevent and also manage the disease. The Diabetes Association, as a member, I rose to become the outreach coordinator of diabetes in my state. The first thing I did was to go from house to house and enlighten women in Powder about the complications or how to prevent themselves from getting the disease. And if they have the disease, I tell them on how to manage it. Then also we go to villages with doctors, nurses, dietitians to go and enlighten the people there. Because people in the village believed that they don't even know about diabetes. They believe that it is spiritual. So they try to treat them in a traditional way. So we go there, we try to enlighten them that diabetes is real. It does not know gender, age, race, or any religious affiliations. So we have to accept it. In our outreach awareness, we go with doctors, we go with dietitians, we also go with lab technicians. We take their samples. If we find out that you are diabetic, we give you free medications, and also at times you go with food. Because people in the village, their own problem is poverty. They don't have enough to cater for themselves. It's not even about popping drugs, but taking the correct food for diabetes. People in the village, at times we find out that not all of them are diabetes, that have diabetes, but at times it's hunger. At times it's lack of education. They need more education so that they know what diabetes is to prevent themselves. During my interaction with the villagers and my activities, I came in contact with Blue Circle, IDF Blue Circle Voices as a member. This has given me more insight on how to go about awareness, about how to preach awareness to people in the village and in the city. So in the city, what we do to them is we held monthly meeting whereby we call them, the doctors explain to them, we explain to them in their own language so that they understand what diabetes is. If they have questions, they ask, and the doctors or dietitians answer them. At times when we go there, I introduce myself as a person living with diabetes. That is the only way you assure them diabetes is not a cause. People should come out and accept that they have diabetes so that we can go forward, so that we know how to manage it and even prevent it and even chase it out of the society. Through Blue Circle Voices, I am also a member of an advisory committee member of non-communicable diseases. With all this experience, they invited me to go to Uruguay and also have more insight on how to help our people. What I understand during all this process is that people, our local people, don't have enough Western education to comprehend what diabetes is. So I sat down and wrote a book. This is the book, although not yet published. What I call Hasken Rayuwa ga masu ciwon suga. That is enlightenment to the people that have diabetes. There are pictures of complications of diabetes here with amputated legs and eyes so that they can see and read in their own language. And also there are menu food that they should take. We are very happy in my own area that we have green vegetables that we take. Okay, also, the association, my own association, Diabetic Association, tried in as much as possible to sensitize the people to know how to take care of themselves. At times, we get contribution from the government. At times, we don't. So with the little we have, we call them as an assistant and assist them. What I found out during my outreach is that there are no access to medicine and care. In the rural areas, the rural health centers don't have enough medication, or even nothing exists like that at times. So people find it very difficult even to find out, to go to the hospitals and find out if they have diabetes or not. Also, the medical personnel are not enough to sensitize the people. Even the doctors, we don't have enough doctors that will sensitize the people, that will cater for the needs of the people. There is no diabetic medicine. Even if there is, they are very expensive. They are not affordable to the ordinary people. Like the glucometers, only few percentage of people that have glucometers, like maybe 10% of the society. The drugs, if you find the drugs, it's very expensive. The drugs there are not affordable to the ordinary person. So what do we do now? The best way out, I think, is the government should come in. It should pass a bill. The legislature should pass a bill that medicine for diabetic people living with diabetes should be subsidized, or even be given free to the society, so that we can fight this disease that is becoming menace to the society. The pharmaceutical companies should also come in so that they subsidize medication for the use of the diabetic patients. The government should retrain and also train members of the society, personnel, medical personnel, so that there will be enough medical personnel to cater for the needs of the people. And also, the society themselves must be involved in their own decision. They should be involved. The local people, the diabetic themselves, the religious society, all should be involved in the fight against diabetes. I think that is all I have for the diabetes. I wanted to talk more, but we have time limits. I am not a person living with diabetes alone. I see that I try to come here so that I can share my experience with others. I have another health challenge. I have leukemia. That is why you are seeing me now. But I pray something better will come up. I hope my story will inspire others. Thank you.
Thank you, Rakiya. I'd like to now introduce Gopika Krishnan from Kerala, India. She has worked with the Diabetes Education Department at, I will mispronounce this, Jyothides, not so bad, Diabetes Research Center for the past 8 years. And she's involved in educational outreach campaigns. Gopika will share with us the challenges of diabetes education and working in a multidisciplinary diabetes team for patient care. I think you have to have them put your slides in.
Thank you, Dr. Riva. I thank International Diabetes Federation for providing me an opportunity to speak on diabetes education. I also thank my mentor, Dr. Jyotidev Keshavdev, for providing and guiding me through the slides. The ultimate objective of a comprehensive diabetes education and our duty as a diabetes educator is to bring back the smiles in our patients with diabetes. But unfortunately, in reality, irrespective of the geographical location, the treatment of diabetes is a failure. Only less than 4% of the patients achieve all the 3 targets in diabetes, as you can see from this study. Now, why is diabetes a disease of failure? The simple answer is lack of knowledge on a very complex disease, and this is because each patient is different and there exist many gaps in learning and understanding of the disease. This is exactly why diabetes education is considered the cornerstone in diabetes management program. Now, if you look at the reasons for failure in the diabetes treatment, we can see that a trained diabetes educator will be able to resolve each one of them. Therefore, diabetes education is a collaborative process through which people with or at risk of diabetes gain the knowledge and the skills needed to modify behavior and successfully self-manage the disease and its related conditions. And research has demonstrated the importance of individualizing diabetes education to each patient's needs. Numerous studies have endorsed a multidisciplinary team approach to diabetes care, education and support, which is most often imparted by diabetes educators. The major areas to focus in diabetes education include overcoming the denial of the disease, modulating the attitudes and behavior of the patient, alleviating the fear of injections, identifying lipodystrophy, hypertrophy, etc., training on SBG technique and schedule, reminding the patient on regular physician visits and lab investigations, customizing the education on the saving cost in diabetes, for example, early insulinization, safe polypharmacy to address lipids and blood pressure, and to prevent costly complications in diabetes, educating the patient on the importance of pneumococcal and influenza vaccinations, and to help the subject titrate the dose of medications as per the existing rules of the clinic. Now let me share with you a couple of examples of the strategies that we follow at our center for imparting diabetes education. My experience is mostly from India, but I'm sure similar circumstances will be prevalent in most other parts of the world. Approaches such as one-to-one and group diabetes education, which are interactive and patient-centered, have been shown to be highly effective and creative. Each methodology will have its own strengths and weaknesses. For example, in a one-to-one diabetes education, the patient will have the confidence to open up to the diabetes educator on their personal difficulties, on their craving for sugar, sexual dysfunction, etc. While in a group diabetes education, the patients will interact themselves with each other and most of the topics would be resolved. Most of the topics would be dealt with. Yet another strategy is retraining on the insulin injection techniques, since there are every chance that when the patient is initiated on injections, due to the fear and anxiety of initiating on injections, they might forget many important steps. According to a retrospective analysis conducted at our center on the impact of routine brief diabetes education sessions in improving diabetes treatment outcomes, we identified individuals who exhibited falls despite attending repeated education sessions. And we could find that 20.1% of the patients chose the wrong site of injection, 35.6% of them practiced incorrect injection techniques, 11.9% did not follow injection site rotation, and 18.8% presented with lipodystrophy or lipoatrophy. It was also observed that there was a significant correlation between the presence of lipodystrophy or lipoatrophy and the site of injection, injection site rotation, proper injecting procedure, etc. And when these patients were followed up after 6 months, there were significant mean changes from baseline for HbA1c, FBS, and PPBS, which reinforces the importance of retraining on insulin injection techniques. Now, how do we alleviate the fear of injections? Experience-based delivery methods are imperative to bring about meaningful behavioral change and to address the psychosocial fears and concerns of the patient. And this is how, if all the common steps fail, I convince my patient on how simple and painless are the insulin shots. I'll inject upon myself to demonstrate to the patient, and in my experience, not even one patient failed to start injections after this. Needle reuse is more of a challenge in a resource-limited setting where the patient need to pay out of their pockets, and many a time we can find an affordable patient reusing the needle, the lancet, or using the infusion set for more than 3 days despite repeated education sessions. And it was a compelling indication for us to develop the insulin pump guidelines for India and for the developing world, where I was also fortunate to be a co-author. Moving on to telemedicine system, ours is a telemedicine-based center since 1999, where we make use of a unique software and a multidisciplinary team, and the patients report 4 blood sugar values and other details either via phone, email, or Secure website, and a virtual consultation takes place, where the dosages of the drugs may be modified and advices on diet and exercise are also given. There also occurs repeated education on the technique of insulin injection, compliance to drugs, reminder for the next physical visit to the hospital, etc. A picture paints 1,000 words, and education on the cost and disability can be conveyed to the patient through a simple picture, so that the need for comprehensive care in diabetes can be conveyed to them. With the onset of each micro and macrovascular complication, the cost escalates several fold, and this will convey the necessity to spend time and resources for proven affordable care. This is a physician program where we promoted Zumba dance as a fun way of promoting physical activity. We also encourage our patients to participate in such group activities, spreading the strong message that physical activity is good both in health and in disease. World Diabetes Day activities help reach out to a wider audience in terms of diabetes education, and we have been observing World Diabetes Day since 2000, and the sweet journey that we conducted 4 years back attracted the audience. And this year the theme of IDF was Women and Diabetes, where we lighted the giant mermaid blue, symbolizing strength, beauty, and compassion to generate awareness about diabetes. A trained diabetes educator needs to be an efficient counselor, and she needs to master the basics of psychology to deal with difficult patients, and she needs to be a good listener, a patient listener, and the counseling should be repetitive and at periodic intervals. Gestational diabetes mellitus is at another challenging area where the educator needs to work along with the gynecologist and the diabetes treatment team. Though the disease is for a short duration, more intensive education is required, and the counseling should be to achieve more stringent targets. We should also overcome the cultural barrier of injections if necessary, and there is a necessity for more intensive glucose monitoring, not only to prevent diabetes in the mother, but also to prevent the future onset of diabetes in the child, which acts as a very powerful motivating statement for pregnant mothers with diabetes. And Keshavdev Trust Type 1 Sweet Stars program was one such initiative where we provided free insulin pumps and accessories completely free of cost for those economically challenged type 1 children who were uncontrolled on multiple daily injections. Elderly living alone with diabetes is yet another growing concern all over the world, and diabetes educator needs to act as a counselor, and the challenges include psychosocial issues, memory loss, visual or hearing impairment, tremors, etc. And the diabetes educators need to identify somebody who can lend a helping hand to these patients, and we need to select monitoring and injection devices to match with their disabilities. For example, if there is a partial visual loss, the click sound of the pen can be taught to count the units of insulin, and the glucometers with wider displays may be preferred. We can also arrange home visits if possible. Newsletters are an efficient way of diabetes education. We have been publishing a monthly diabetes newsletter since 9 years, and we have been very particular in including all the new scientific information which could directly benefit the patients, and it has been subscribed by more than 60,000 patients. So the bottom line is, a successful diabetes educator should combine the qualities of a friend, counselor, and a coach. And diabetes education and educators are pillars of success in diabetes. More quality time and customized diabetes education should be in place, and being in an active role in the team can change the life of those with diabetes. And we should also have appropriate continuing education programs to diabetes educators to ensure continuing competence. And I believe that is why we all are here. Thank you so much for your patient listening.
Thank you, Gopika. I'd like to introduce our third speaker, Phyllisa Derose. Phyllisa is an English literature professor and a Blue Circle Voice member who's actually, I think, originally from the US and now living in the UAE, actually from Florida. Diagnosed with type 2 in 2001, and something that I wasn't given in her bio, but that she told me just before this presentation, is it took her quite a while to actually put her name on her blog. And there was some concern about discrimination when you identify that you have diabetes. So it's just an interesting point of what it's like to live with this condition that many of us are living with. But Phyllisa, since her diagnosis, has done some amazing things. She's become a very prominent diabetes blogger and advocate. So she's going to give us an overview of the main diabetes issues in the UAE compared to the US. And also, she will touch on prevention for us and a little bit about diet. So please welcome Phyllisa.
That's what I'm talking about, a little energy. Hi, everyone. I'm so glad that you are here today in this presentation. You could have been in many others, but we are very thankful that you are here. I'd first like to give honor to God for my presence and being here today, and as I tell my story of how I've become here, you'll be thanking Him too. Next, I'd like to thank IDF for this wonderful opportunity to be a speaker today, and for my fabulous panelists who have not only encouraged me, but we've encouraged each other. Thank you. So the first thing I want to do is I want to tell you a little bit about how I come to this stage. I moved to a new city after getting my PhD in English literature, and I started to feel tired. And then I gained another symptom. That other symptom was extreme thirst. Along with that came frequent urination, also vision loss. My vision was getting blurry. And I had gone to a doctor and I said to her, I'm new to the city and I'm experiencing these symptoms. Can you tell me what's wrong? And she said, of course I can. You're working out 5 days a week. It's your electrolytes, they're off. You need to drink Gatorade. So a week after drinking Gatorade, I had passed out in my bathtub for an unknown amount of time. All I know is that I had run a hot bath, and when my consciousness came through, it was freezing cold. So when I say to you today that I'm here by a blessing, I really mean that, because I don't know why I woke up. But the fact that I did, I tell everyone my story. I went to the doctor the next day and I told her I'm not exactly sure that Gatorade was what I needed, because in addition to the symptoms that I explained to you last week, now I'm having many more, and they include conscious issues. So for example, I was given a lecture to my students about the Emancipation Proclamation when it was signed in 1865. And I know this like the back of my hand, but in class I said something like, in 1982. And I would hear that and I said, there's something wrong. So I go back to her. At this point in time, they register, they check my glucose. It doesn't register. All they get is the letter HI, high. My doctor leaves the room. Her assistant whispers, your glucose isn't registering. That's not a good thing. Totally freaked me out. I call my mother. Ma, they say my glucose isn't registering and that's not a good thing. My mother's a nurse. She said, that isn't. You need to go to the emergency room. So I told my physician when she entered the room with the syringe, which probably was insulin, but she never told me exactly what it was, that I needed to go to the emergency room. She says to me, you would have to sign a waiver that you're going to the emergency room against my advice, because I don't think that you're a case for the emergency room. So I gladly signed the paper because I'm the kind of child that follows their mother's advice. When I get to the emergency room, I can no longer stand. I'm going into a diabetic coma. They check my blood glucose level. It's 593 after the insulin that my physician had given me. So 6 days in the hospital, I was told that I have diabetes, no idea what it is. I was given old pamphlets. The pamphlets were vintage, tinged yellow. No one on the pamphlets looked like me. They were not young people. I was confused. I didn't know what diabetes meant. No one in my family had it, and I felt totally lost. So 61 days after that, I lost my home in a tornado as well. So I had a very dark period in 2011, 6 years ago. Through getting through the diagnosis emotionally, and then also the horrible experience of leaving your house one day and coming back to discover a tornado has taken everything to Kansas, I had to pull myself out of an emotional rut. And part of what helped me do that is I developed a motto that I was diagnosed, but I was not defeated. That I was a person living with diabetes and not dying with diabetes. So my talk today, I'm going to tell you about 3 areas. One, in terms of diabetes education and educating people about diabetes, oftentimes physicians say things like, you have to exercise. These are blanket statements that don't really mean much when we don't know exactly how. So when I hear you need to exercise, when I was told that, I didn't know, did I need to get a gym membership? You know, how do I do that? What do you mean? And so what I've noticed in my personal journey as a person being diagnosed with diabetes is that there's a gap. There's a gap between the information that healthcare providers give people living with diabetes and then the real life experience. And so a year later, I started a website called Black Diabetic Information. And Black Diabetic Info is to help bridge that gap. My blog, Diagnosed Not Defeated, is to help bridge that gap. So what I do on my videos and on my posts, I say, listen, you've heard get 30 minutes of exercise a day. You don't need a gym membership to do that. How about when you go to the grocery store, you do a couple of laps around the grocery store before you start shopping? I come from a church in South Florida where we don't sit down to praise God. We're standing up, we're jumping around, we are running around the church with worship. And so I tell people that that could be your form of exercise. So I reach the community that I'm from, a community that oftentimes when we sit in physicians' offices, they're not recognizing that. So when they say things like, you can take a walk in the evening, well, taking walks in the evening in certain neighborhoods isn't safe. And so how do you deal with that? So I tell my viewers and people who follow me the ways in which I get exercise when I'm in a particular space and community where I can get exercise by taking walks at night. Also, when it comes to diet, you hear things like eat right. What does that mean? Plate method. You want to know what kind of plate method I grew up on? I grew up on the clean your plate method. My mother said, clean your plate. My grandmother said, clean your plate, and that's what it meant. And so when you talk to a nutritionist and they're telling you to eat this and that and have small portions, but grandma says you better eat another portion because you need some meat on those bones, then there's a conflict there. And so what I do again is I help bridge that gap. So I show images of the plate method. For example, I am from the Miami area in South Florida. However, my family originates from South Carolina. And there's a group of people in the United States called the Gullah Geechee people. And these are people who are descendants of the American slave trade that have maintained some of the culture that was taken from them. And so we have our own particular belief systems and cultural norms, and one of those is coming up. It's New Year's Day. On January 1st, we have to eat a particular meal. We eat Hoppin' John and collard greens. And we eat Hoppin' John because it brings us health. And we eat collard greens because it brings us wealth. Now, in my neighborhood, no matter whose house you go to on the 1st, you're going to find Hoppin' John and collard greens and rice. And so I present the plate method by showing these types of food. I show dressing. I show macaroni and cheese. Again, these are items that when I see a nutritionist, they're not there. If you've gone and seen a nutritionist and they have the fake food and they say, fix your plate with the fake food. I haven't seen collard greens and turnip greens and mustard greens yet when I've gone to see a nutritionist. I haven't seen Hoppin' John yet when I go and see a nutritionist. So I'm helping to bridge that gap. Next, I want to talk about some of the things that I noticed when I moved here. I moved to the UAE in 2013 as a U.S. Fulbright scholar for 1 year. And when I moved here as a person who managed their diabetes without medication. I was diet and exercise only for almost 3 years. I moved here and I went to a diabetes clinic, and when I went there, my entire visit cost $15, which was a big difference in the $300 that I was spending a month in America. So in terms of prevention and in terms of care, this is something that Americans need to be aware of, is that in other places, they are not dealing with the high cost of managing diabetes. Also, I noticed similarly to when I was in America that some of the nutritional information, some of the prevention information around diet and exercise was not culturally competent. And so here, they eat gamat. If you were at the opening ceremony and you saw this big silver bowl with these little balls in them that were sweet and yummy, I know, the name of that is gamat. Well, when you go to a nutritionist here, you don't see gamat. A traditional Emirati food is harish. When you go to a nutritionist, you don't see harish. So this year, I started a support group for people here in Al Ain. And in that support group, I help bridge the gap. So I find that my work as a person living with diabetes, as a diabetes advocate, I take it wherever I go because I'm constantly seeing that gap between healthcare providers and people living with diabetes and our day-to-day encounter with food, with exercise, with culture, with ways of being and ways of living. And so, to conclude, I just want to say that it's important for us as advocates, it's important for us as advocates to maintain our service, to continue to fight the fight, to continue to bridge the gap, because the gap is in fact there. And I just, again, want to thank you for attending this session. And that concludes my part. Thank you.
Thank you, Phyllisa. Or Phyllisa, I've been corrected. Can we put up the slide that has lots of pictures of different people? I asked to put this up because I started out by saying there are 130 Blue Circle Voice members from 58 countries. And whenever we talk about statistics, we forget that those statistics are really real people. So if you're interested, on the IDF Blue Circle Voice website, there are a number of videos that members of this network have made, only 1 to 2 minutes long, about, actually the topic was discrimination, but you'll learn a lot. And I learned when I actually made this slide that I like to talk, because mine is the longest, 2 minutes and 26 seconds. But you will forgive me for that, I hope. I come from the US. I live in New York City. And often when we think about diabetes, healthcare, access to care, access to medicine, affordability, we think countries like the US, that's not a problem. We tend to talk about things like this in terms of third world countries. Without a doubt, it's a problem there. But I would have you understand that even coming from the US, we have a lot of similar issues that we face. If you follow the news at all, you will know that our healthcare insurance system has just been in total disarray this year. Lots of people are afraid they're not going to get insured. People living with conditions like diabetes may not be able to get health insurance. So these are issues that all of us face around the world, not only in certain countries with certain incomes. So I wanted to speak a little bit about discrimination, and then we'll answer a few questions for you. And I broke this up in a way, 3 different forms of discrimination living with diabetes. One is the one that's probably most obvious. It's visual. For myself, I was going through the Heathrow Airport in London a year or so ago, wearing my continuous glucose monitor, which I'm wearing now, and the airport security officer got very angry at me because I asked for a pat down instead of going through the machine because of my medical device. And she threatened me that she was going to put me in a private room and interrogate me and do a strip search. And I was really beside myself. I had never faced something like this. And I tried explaining to her very kindly and calmly there was no need for that. Finally, I took off my jacket and all of that. I showed her my device, and she calmed down. But for me, that's a form of discrimination. And one of my fellow Blue Circle Voice members, Anna Norton, just spent 2 days getting here from the States. It was a really arduous process for her, and during it, also going through airport security, the pat down was so rough that they almost ripped her insulin pump off. So, you know, maybe this doesn't seem like the typical form of discrimination, but why should we not be treated with respect? Why should every individual not be treated with respect? And when you walk around with diabetes, sometimes you're just walking around with an extra thing you have to take care of. And we would certainly all appreciate if people were a little bit more kind and respectful. A second form of discrimination is one that really affects people getting proper care. So it's been seen in surveys that the majority of people with type 1 and type 2 diabetes feel that they are discriminated against and actually report the statistic is 81% of the people who took these surveys reported that they feel the general public perceives them as having a character flaw or a lack of personal responsibility. This is largely because the general public doesn't understand diabetes, what it is, what it takes to manage it. And so when people feel that this is the general attitude about them, often it stops them from going to their healthcare provider visit. If we don't have people getting education, then we make our problems bigger. So this is another form of discrimination that really affects people on an emotional level and on an ability to manage their condition. If they feel so stigmatized, they don't go to their appointments with their healthcare providers. And I want to touch on a third type of discrimination. And it's often in the general public, but to be honest, we often find it amongst healthcare providers, a kind of unintentional discrimination. And for me, it seems twofold. One is in the language that we use. So we use words like diabetic and patients. Well, I'm frankly only a patient when I'm in my doctor's office. The rest of my life, you may call me a person with diabetes, but it would be foolish to call me a patient. But we are loath to recognize these types of language issues. We talk about adherence and noncompliance. These are medical terms that too often people with diabetes are subjected to. In the personal work that I do, I actually teach healthcare providers that we are not machines. We are human beings. And we should not be judged like machines with the idea that we should be adherent and compliant and that it's just a matter about controlling your numbers and precision and accuracy. Last night, after my dinner, being on jet lag and all, I forgot that I had given myself a certain dose of insulin, and so I gave myself a little bit more when I decided I was going to eat dessert. I actually only ended up eating one bite, and from about 8:30 in the evening to midnight, I was eating honey and jam to raise my blood sugar. I felt unsafe to go to sleep. And at the same time, I was noticing my friends, also who have diabetes, many of whom are here, posting on Facebook that they were going through something similar. We are not machines. We are human beings. We live with non-functioning pancreases, and yet somehow there's an expectation that we should be perfect at this. I think that's another inherent form of discrimination. It's in the language that we use. Testing blood sugar, meaning there's pass and fail. As I mentioned, adherence, compliance, diabetic, patient, control. I think we need to go back and look at our language and look at how we treat people. We need to get access to medicine and care. But if you have access to medicine and care, and you do not have healthcare providers partnering with you and supporting you and respecting you, then we are not going to be entirely better off. So that's just one of my personal peeves, shall we say. I want to touch on the fact, too, that it's certainly not all gloom and doom. One thing that's happened in the US is the collaboration of certain diabetes organizations, like the Juvenile Diabetes Research Foundation, like a group started by one of my fellow persons with type 1 diabetes, Deepak, has persuaded the government to include coverage for continuous glucose monitors for people over 65 who get Medicare. And oddly enough, people over 60 with type 1 diabetes are the most vulnerable population to low blood sugar and hypoglycemia unawareness. So how silly was it that we weren't covering this for people in Medicare, and now we are. And also, I think one of the great things that we have at our fingertips, and we want to make this more active amongst the Blue Circle Voice members, but it's the idea of peer support. For 10 years, I was a peer mentor in the States, and I went across the country talking to fellow people with diabetes, giving short educational programs. And honestly, what they heard from me in the type of medical information or the taking care of your diabetes information I was giving them, they have heard from their doctors and their nurses and their diabetes educator, but when they heard it from a person living with diabetes, they heard it completely differently. They took it in a completely different way, and I remember going to give my very first program, and I was nervous. And I had 25 people out there in a support group for diabetes. And at the very end, one woman came up to me and she said, "Oh my God, I got it, it's up to me." So she really understood, just from hearing me say the same things I'm sure she's heard from her healthcare providers, that we need to take responsibility. If we're living with it, we need to take responsibility. We can't just rely on our healthcare provider. At the same time, I would influence you to think it's not merely a personal self-management issue. We also need society to step up. It's also a societal issue. We need to improve making it easy to make healthy choices, as they say in public health. People will make the healthy choice when the healthy choice is the easy choice. So there are some successes. We will have more successes. I should tell you a little bit now about myself because I have not really shared my story. My name is Riva Greenberg. I have type 1 diabetes. I've had it since the age of 18. I'm 64 years old, which means I've had it, you already know, right? You've all figured out the math? If not, 45 years. I can remember 45 years ago, I was basically told, don't eat candy, and I took 1 injection of insulin a day. It took 10 years for home glucose meters to come out, so I never knew where I was. We had urine sticks, which I've since learned gave your blood sugar 4 hours later, and the color chart was so muddy you couldn't figure it out anyway. We had very few tools. So I have truly seen the invention of amazing things in my life living with type 1 diabetes, and all the things that are in the pipeline and all the things that are on the horizon that I'm extremely grateful. After a career in advertising was really to design a different way of working with people who have diabetes for healthcare providers, and I call it the flourishing treatment approach. Resources are what they feel they're willing and able to do. So it's a real partnership, and I believe we really have to change the tenor of the interaction and be respectful and realize that there are 2 experts here, the healthcare provider and the person living with diabetes. And I am happy to say I've shared this the last couple of years around the world, and the reaction has always been one of incredible enthusiasm, and it resonates. Because one thing I'm convinced of is people who go into this field as healthcare providers absolutely want to help. Absolutely. And it's often a struggle for them because they're not properly trained helping people who live with a chronic illness like diabetes. So With that, I want to thank you, and I'm going to pose 2 questions to our panelists, and then I invite anybody in the audience who has a question for any of us to please come up to the microphone and ask us your question. If you would like to answer, what one thing do you think we could change about diabetes, whether it's about care, what we know about diabetes in the general public, anything about diabetes and our care and treatment that you think would make a big difference for people living with it? Anybody have a thought about that?
I believe that we need to empathize with the patients. We need to motivate them, and we need to have a try and alter the mindset of the patients living with diabetes, that it is a disease which is known to be confided to others, but they should try and open up, and we as carers or doctors should be able to empathize with them, so that they can open up on their personal difficulties. For example, the lack of support from their spouses, or sexual dysfunction, which most of the patients are fearful to confide, or craving for sugar, or as your story, as you mentioned here, going for a low or a hypoglycemic episode. All those needs to be shared, so that people know more about the disease, and also many common man doesn't know the difference between type 1 and type 2 diabetes, because we have experiences in our center where type 1 kids were treated as type 2 patients, and they were not allowed to go to the washroom. They were not allowed to take the injections during their examinations, because the teacher believes that the kid is having the same diabetes as her diabetes. So these type of misconceptions will be changed if more and more people speak about diabetes, and the carers and the common man empathizes with them.
Thank you. Phyllisa.
For me, it is the cost of managing diabetes. Like I mentioned briefly in my presentation, that I am American and have been living in America until I got the Fulbright here. And when I was diagnosed with diabetes, my entire savings went away. Like, I went into a deficit, and it affected every area of my life. It affected when I could fly home for holidays, when I could go home for family reunions and things like weddings and funerals. I just simply couldn't afford it. It also changed the way in which I worship. I had to change the church service that I went to. I used to go to 11 o'clock service, but I couldn't afford going at 11 and then going to the gym, going back home, and gas for the week. So I started going to the 9:30 service at church because it ended at 11, and then I could go to the gym that opened at 11 and then home. Like, literally, this is how much the cost of insulin and strips affected my life. Coming here where it's much more affordable, I don't even think about that. And so for me, it would be making the price of managing diabetes something that's not a financial burden, in addition to it already being an emotional burden.
Thank you.
Okay, as for me, I want to see that diabetes should be made to have a human face. It's not something that is as dangerous as people might think. And also, I want to see that people living with diabetes are involved in their own decision making, what they want, what they need, and how to improve themselves. I want to see that the policymakers are making things easy for people living with diabetes. If they can provide free medications to people living with HIV or living with AIDS, I think the privilege should be extended to people living with diabetes, especially people coming from the countries that that are low income earners. Thank you.
Thank you. And the other question I wanted to pose is, how do you think we can make the patient voice stronger, louder, more heard?
It's still almost the same question. The idea of Blue Circle Voices is another channel that is changing the perception of diabetes. I think with this is the right kind of channel that we can use to beat diabetes. Okay, let me allow them to add more.
I also agree with her. Maybe creating awareness through social media, as the Blue Circle Voices is doing, and maybe creating more awareness or group education sessions where we can talk about diabetes, the problems, the discrimination, and also the prevention aspects of diabetes can help us reach out to a wider audience.
For me, it would be doing things like this. For example, there is a Persons Living with Diabetes stream here at IDF. I've gone around the convention center, the exhibit hall. I see tons of flyers about this upcoming diabetes conference. And I've gone and I've asked most of them, I'm not a physician, I'm a person living with diabetes. Can I attend your conference? No. I mean, it's like dragging out, but ultimately, no, we are not invited. People living with diabetes are not invited to diabetes conferences. This is a problem. And one of the things that I discovered for this past World Diabetes Day, I put on an event, Diabetes Awareness Trivia Social, here in the UAE. And I put it out on social media and everything, and I invited everyone to come. And there was a woman who was a physician that came. And after we played one of the games where I put people, whomever's in the audience, in the mind of living every day with these choices, she said, you know, I had never thought about it this way. I had never thought about what it must be like to sit in a restaurant and see kanafa. If you live here, kanafa is a dessert. If you're from somewhere else, think of the best, yummiest dessert you ever had in your life, whatever that may be. To be in a restaurant and see that on the menu and to know that it's over your carb count. What, in fact, do you do? And she told me as a physician that she had never thought about that because all she sees is the numbers. And she said, coming to your program today, I'm going to walk away being more compassionate. This is what happens when you invite people living with diabetes to your diabetes conferences. And I think that would definitely strengthen our voice and make people aware of what we're dealing with 24/7.
Thank you. And just adding on to that, I spoke about my work is helping train healthcare providers in strengths-based skills, working with people who have diabetes. And the other piece of that is to help people living with diabetes realize that they have a responsibility too when they're with their provider, to speak for themselves, to respect themselves. I said last night to my husband as I was sucking down a jar of honey, you know, I realize it sounds dramatic, but I could say I live with organ failure. Having type 1 diabetes, I don't have a pancreas that works. Now, in the medical community, that might be considered organ failure. Well, heck, I have a lot to be proud of to manage this condition fairly well, living with organ failure every day, every week, every month, every year. That is something to be acknowledged and respected for, both by healthcare providers, but amongst ourselves. So, I hope we begin to wear the blue circle with pride. I hope we begin to feel pride in what we're doing in our lives and how we're living with diabetes, and continuing to share the message that it's about empowering people living with diabetes, as well as providers in healthcare and the public. So with that, can we turn the lights up and maybe ask if anybody has a question?
Thank you, all of you, for the amazing talks that you gave, and I'm moved, I would say. I really want to know, is the right way of presenting yourself to a healthcare professional when you go to them? It's more of a boss and a subordinate relationship. It's hard to tell them how you feel stepping into the office, how you feel living with it day in and day out. What are the challenges that you face, because there are so many and they have so little time to understand. Has anyone ever thought of giving a person with diabetes with a toolkit that helps them communicate with the healthcare professional that they consult?
Okay. Anybody want? So how do we show up with our healthcare providers, expressing the respect we have for ourselves, and to help them better understand what this is like to live with? More or less, Sana? Okay. Anybody like to take that?
Well, I can say, because I do run diabetes programs, again, in America and here, one of the things that I do is I encourage people who come to these programs to write down all the questions that they have. Because oftentimes when you see a physician, you've kind of forgotten maybe something that has happened. And I also encourage them, in addition to taking the notes, to remind them that it's their care. I typically share the story of when I went to a gynecologist and he told me that I needed to drink cranberry juice. And if I didn't speak up for myself as a person living with diabetes, I would have just walked away and either taken the cranberry juice and had hyperglycemia, or decided he doesn't know anything and not take it. So I say to him, well, I can't really go around drinking cranberry juice. And he says, oh, well, then I'll prescribe you cranberry pills. But we would have never gotten there had I not spoken up for myself. So I share that with people, and I do give them tips, but in terms of like an actual like checklist or program that you've suggested, I haven't done that yet, but I will write that down, Sana.
In my case, I work in a comprehensive diabetes care center where the decision for a patient on what injection to choose, on what medications must be given to the patient, is a shared decision making, as far as I know. Because when the patient walks into our clinic, then they are given 3 levels of treatment, whether they need to opt for the standard care, the limited care, or the comprehensive care. They can choose on themselves based on their pockets, based on the resources. They can choose which standard of care they must be choosing, and then they'll be asked to follow all the blood tests and the investigations, and based on the resources that they have, the doctor would discuss with them on the medications that they need to be on, or if insulin is suggested to them, whether they would opt for human insulin or an analog insulin. So I believe it should be more of a patient-centered approach, or a shared decision-making should be there. And it shouldn't be like what Madam mentioned. It shouldn't be like a boss and a student relationship. That's what I feel.
Of course, you are an enlightened healthcare provider. You are an enlightened healthcare provider. I'll share a personal example. I was with my podiatrist, my foot doctor. I had injured my foot, And I was very nervous about it. I certainly know how vulnerable feet are for people who have diabetes, and I was really concerned. And my podiatrist took an x-ray, and he came back into the room where I was sitting, and as he walked past me and had his back to me and put the x-ray plates back in the closet, he mumbled something. And I said, "Please, I didn't hear what you said. Would you turn around and tell me what you said?" So he was a little surprised. And then he turned around and he looked at me and he told me that I was going to be fine. So I think there's, we have to educate. As a friend once said, you have to educate up. You have to educate the doctors. And part of that is, frankly, how we show up. I will ask questions. I ask lots of questions, and I'm not satisfied if I don't get answers. I had an endocrinologist before who took a lab test, and it was out of bounds, so he retook it, and I never got told what the result was. I called 4 days in a row, and no one ever called me back. So finally, the 5th day, I left a very angry message and got a phone call back, and I was told, "Oh, well, we don't call patients if everything's okay." Well, how was I to know that if the first test wasn't okay? So I fired my doctor. I went and I found another doctor. Yeah, so it's a combination. Ask questions, respect yourself. It's your condition. It's your life, and we have to train the people that we interact with. Question?
I would like to make a comment. I myself has diabetes, and I'm a healthcare professional. So I must say that first of all, as being a patient, as being a person with diabetes, we should voice our ideas. We should say it out that we are okay, we don't have any disorder, we are perfectly fine, we are living like you, we have heart like you, we have feelings like you. So first of all, we need to learn that how to voice out these things. And after that, we will get respect from healthcare professionals. Because somewhere we feel like we are inferior. We need to address this issue first, and then they will respect us.
I wish to thank all the presenters. I wish to share, it's a form of a question and also a form of contribution to these Blue Circle voices. One of it is one of the panelists, presenters said that in most places, in most countries, there is this big challenge of maybe partnering with the government and see how they could come in. But most of the places do not have those opportunities. If I'm not mistaken, one of the presenters is from Nigeria, and I'm from Nigeria. I got to know much about diabetes because my mother, my father, they died because of diabetes without having any knowledge about it. I did my studies partly in Italy, Ireland, UK, and America. So I'm back home, and I'm a lecturer too, but I have a concern. Back home, people don't know much about diabetes, first of all. Second is stigmatization. But there are no efforts by the government to assist some of these people I decided to found a foundation, Diabetic Foundation, which all my efforts, I have to get in some of my brothers to join me to create awareness. And most people during the seminars or conferences, random testing, teaching them type 1, type 2, I was forced to write a book on introduction to diabetes, just to share it out, share the flyers out. But you come and see that after the test, after the talk, after the random testing and so on, voicing out in a workshop, in a seminar, you do this free. And majority of them are either type 1 or type 2 diabetic patients. And after it, one of the presenters said, what next? What next is my question. Most of them have no access to drugs. Most of them have no access to glucometers or strips. And nutrition is another problem. But IDF is trying so much, the little they can or much they can. But I'm appealing that the Blue Circle voices should move a little bit out of the capital cities or commercial city centers to put up diabetic seminars, associations, programs to enlighten the less privileged in our societies. Otherwise, they feel in some places they have type 1, type 2 diabetes, but they feel that it is a form of voodoo or kind of local charms that's maybe from their relations or from their brothers. They don't even know or are aware of what is called diabetic coma, that somebody could get into coma and afterwards. And you see, after that, the next Sunday, they go to church for Thanksgiving, dancing to God for saving them from the enemies, all right? And there, too, the meals are not proper, the nutritional. I mean, just to be precise, I am asking, requesting if some of these places could be helped. I have tried to put up a diabetic center, calling Dr. Friends. I'm a medical sociologist, but putting up some of these things are really, really, really big challenge to us. We're asking for health care providers. Some of them I have met personally said, well, we go to areas where we can partner with the government so that the government can really come in.
So with that, I'd like to thank everybody for coming. Thank our panelists.
Thank you.
Wish you well. Thank you.